Good afternoon. My name is Kelly McCrum. Today, I will be presenting on evaluating anticoagulation from low molecular weight heparin in hematopoietic stem cell transplant recipients. Myself nor my advisors have anything to disclose for this presentation. Today, we will discuss current literature addressing enoxaparin use in transplant patients, describe the study design and assess results, and identify anti-factor Xa level trends in patients receiving therapeutic doses of enoxaparin and have a diagnosis of leukemia or lymphoma, or have received a hematopoietic stem cell transplant. Patients with active cancer are at an increased risk of both venous thromboembolism, or VTE, and bleeding events. Cancer impacts all three elements of Virchow's triad as demonstrated on the slide. Certain cancers, such as hematologic malignancies, are associated with even higher risk of thrombus compared to other malignancies, but this must be balanced with the increased risk of bleeding that these patients also experience due to prolonged thrombocytopenia. Enoxaparin works by binding to and potentiating antithrombin to form a complex that irreversibly inactivates clotting factor Xa. This is why anti-10A levels are used to monitor enoxaparin's efficacy. An elevated anti-10A level means less clotting factor is available, thus there's an increased risk of bleeding. In a typical patient, anti-10A levels do not need to be monitored when enoxaparin is used due to its linear and predictable kinetics. Historically, in patients with cancer, low molecular weight heparin, namely enoxaparin, has been the primary treatment choice for patients with VTE. The American Society of Clinical Oncology recommends the use of a low molecular weight heparin in oncologic patients for 3 to 6 months after an initial thrombotic event. However, there is no standard protocol established for treatment of VTE in patients who have undergone a stem cell transplant. Although there is minimal published data specific to stem cell transplant, a 2011 study found that solid organ transplant recipients may be a patient population where anti-10A monitoring and enoxaparin dose adjustments may be necessary. The study found that 67% of lung transplant patients receiving therapeutic enoxaparin who had anti-10A levels measured had supratherapeutic levels requiring enoxaparin dose reductions. Additionally, the study proposed a theoretical drug-drug interaction between enoxaparin and tacrolimus, the standard immunosuppressive calcineurin inhibitor used in both solid organ and stem cell transplant recipients. The proposed drug interaction is due to enoxaparin being renally eliminated and the ability of tacrolimus to cause renal impairment through a number of mechanisms. Based on the 2011 study, it was hypothesized that stem cell transplant recipients may be a patient population that may benefit from anti-10A monitoring with enoxaparin. The purpose of this project is to gain insight on safe and effective enoxaparin dosing in patients with a leukemia or lymphoma diagnosis or have undergone a stem cell transplant. To investigate the relationship between creatinine clearance, tacrolimus serum levels, and anti-10A activity levels, and to determine a therapeutic dose in which enoxaparin may be dosed to avoid supratherapeutic anti-10A levels. Between December of 2020 and April of 2021, patients who were prescribed enoxaparin for a therapeutic indication were assessed in the inpatient and outpatient setting in order to determine the most appropriate dose. Enoxaparin was started at the recommended dose of 1 mg per kilogram every 12 hours, and anti-10A levels were collected once the patient was at steady state. Based on anti-10A levels, the enoxaparin dose was adjusted based on a hospital-approved nomogram adapted from clinical literature. Per CHEST guidelines, 0.6 to 1.0 international units per milliliter represents the therapeutic anti-10A level. If a patient was above or below this range, the dose was adjusted, and another level was repeated per the algorithm until a therapeutic level was achieved. Patients were included in the study if they had a diagnosis of leukemia, lymphoma, or previous stem cell transplant and were receiving enoxaparin for a therapeutic indication. Patients also needed to have at least one anti-10A level drawn while on enoxaparin. Patients were excluded if he or she was only receiving enoxaparin prophylactically. A total of 13 patients were identified as meeting the inclusion criteria. Of these 13 patients, 8 had a stem cell transplant in the past. 5 of these were allogeneic transplants. 2 of the transplants were within 180 days of the first dose of enoxaparin given, but both of these were patients who had autologous transplants, so they did not require immunosuppression. None of the patients had renal dysfunction, and only one patient had a BMI greater than 40. Of the 13 patients analyzed in the study, 8 patients had a supratherapeutic anti-10A level that required dose reduction of their anticoagulation. The average dose for these patients was 0.7 milligrams per kilogram. Only one patient required a dose escalation. 4 patients had therapeutic anti-10A levels with 1 milligram per kilogram dosing with no adjustments. There were no documented bleeds in any of the patients. Of the 8 patients who required dose adjustments, only one patient had a BMI greater than 40. 5 of the 8 patients had previously received a stem cell transplant, but no patients were treated with enoxaparin and tacrolimus at the same time. Data supports the notion that traditional 1 milligram per kilogram enoxaparin dosing may cause supratherapeutic anti-10A levels in patients who have received a hematopoietic stem cell transplant or have a diagnosis of leukemia or lymphoma. No conclusions regarding the relationship between tacrolimus, renal function, and enoxaparin levels could be established. In addition, an associated risk of hemorrhage could not be established. Data collection is ongoing as more data is needed to draw any formal conclusions. Larger studies are needed to confirm findings and to determine clinical benefit. Based on what was just discussed, you should be able to answer the following question. Which factor should be taken into consideration when dosing therapeutic enoxaparin? The answer is C, patient diagnosis. Thank you for listening to my presentation. If you have any questions, feel free to contact me at the email address listed on the slide. Thank you.